Hello, I'm Dr. Mohammed Abdelgawad. Today we are going to speak about radiology in general surgery. We will discuss radiological findings in esophagus, stomach, and colon with different diseases. First of all, I want to greet you and invite you to start to take up some hints about the different diseases that we will discuss today. Let's start with the esophagus. We will have some anatomical consideration regarding the esophagus and the anatomy of the the lower esophageal sphincter. This part of the esophagus is very important. It's called the lower esophageal sphincter, and it is a physiological sphincter that separates the esophagus from the stomach. We can see here, this is the esophageal lumen and this is the stomach. We have a protective mechanism that is present in normal population, which protects us from gastroesophageal reflux disease in this area. First, we have this part of the esophagus is called the intra-abdominal esophagus or the intraperitoneal part of the esophagus. Its length is about 4 to 5 centimeter and it's present inside the peritoneal cavity, which has positive pressure and which is considered high pressure relative to the negative interthoracic pressure. The second thing is the crural fibers of the diaphragm, and the right and left crust of the diaphragm, which act as a pinch cock action around the lower end of the esophagus, preventing reflux. Third, we have the circular muscle fiber of the stomach here act as an additional sphincter, and also ligaments around the esophagus like the phrenoesophageal ligaments, which protect from gastroesophageal reflux disease and occurrence of hiatus hernia in normal population. As we see here, what kind of X-ray is this? This is a barium swallow. We can see here the esophagus and the stomach. This is the chest wall. This is the ribs, and this is the vertebral column. This is the lateral view, and this is the anteroposterior view. We can see here part of the fundus of the stomach migrating up into the chest, which is a hiatus hernia. Also, we can see here reflux of the dye from the stomach back to the esophagus, and this is the rest of the stomach and the gastric fundus. So, what's your provisional diagnosis? It's type 1 hiatus hernia, or it can be called sliding hiatus hernia. Now, this is another the same type of the same disease and same problem. Here we can see the esophagus and the stomach. Here, this is a part of the fundus of the stomach. You can see here these folds are called the gastric rugae, and this part of the gastric rugae are present inside the chest. So, this sliding hiatus hernia or um, type 1 hiatus hernia. We can have a question: what are the main symptoms of this patient? How can you diagnose this patient, or what are the additional investigations that you can perform? The main symptoms in sliding hiatus hernia are heartburn and acid reflux due to weakness of the lower esophageal sphincter and the backflow of the acid from the stomach back to the esophagus. We have some typical reflux symptoms like heartburn and regurgitation, and some atypical reflux symptoms like cough or hoarseness of voice. What are the other types of investigations that can be done for this patient? So we shouldn't forget the 24-hour pH metry and the esophageal manometry. Now we will move to the next X-ray. This is another example of a sliding hiatus hernia. This is a part of the fundus present inside the chest, and it's sliding hiatus hernia as well. This is also a sliding hiatus hernia. This is the barium swallow showing backward reflux of the dye inside the esophagus and part of the stomach migrating to the chest, which is called the sliding hiatus hernia or type 1 hiatus hernia. These are the different types of hiatus hernia. This is the normal anatomy of the esophagus and stomach in relation to the diaphragm. Here is a type 1 hiatus hernia, which is called sliding hiatus hernia, and this is type 2 hiatus hernia or paraesophageal hernia. What is the main difference between type 1 and type 2 hiatus hernia? Here, the lower esophageal sphincter is migrated upward in the chest, and this lead to weakness in this area and in the lower esophageal sphincter, and this will lead to backflow of the acid and reflux of the acid inside the esophagus, and the patient suffer from GERD and acid reflux. On the other hand, in paraesophageal hernia, here the lower esophageal sphincter is intra-abdominal, so it's usually somewhat competent and also this part of the fundus lead to compression symptoms over the heart and lung. So this patient feel dizzy after meal and chest tightness after meal. On the other, but he may not suffer from reflux symptoms at all. On the other hand, this is a type 3 or mixed hiatus hernia where parasophageal and sliding at the same time, and the patient suffer from mixed symptoms like GERD and also chest compression symptoms. Now we'll move to another type of an esophageal disease, which is achalasium. As we see here, there is a dilatation of the esophagus with thin tapered lower end with intact mucosa. This is how we will describe achalasia. So how can we write a full description for this X-ray? We will say it's a barium swallow showing hugely dilated esophagus, smooth tapered lower end like a parrot beak appearance. This is the name of the abnormality usually seen in the radiology, parrot beak appearance with healthy mucosal covering, so we can exclude malignancy by this way. So it's achalasia. Now we have to confirm a rule. When you see the organ hugely dilated like here, so it's most probably a benign disease. When you see the esophagus is hugely dilated like this, you think about benign diseases like achalasia. The main pathology of in achalasia is failure of relaxation of the lower end of the esophagus. As we see here, this failure of relaxation of the muscle here, the lower end of the esophagus, lead to spasm in this part and stagnation of fluid and food in the esophagus. You can have a question on this X-ray. What are the symptoms that the patient suffer? He will suffer from dysphagia, mainly to fluids than solid food. What are the other investigation? It's very important to investigate this patient with esophageal manometric study to see the pressure on the lower end of the esophagus. Usually, you will find a normal pressure at the lower end of the esophagus, but during swallowing, this pressure doesn't decrease due to failure of relaxation of the lower end of the esophagus with swallowing. So it's not spastic, it's not high pressure zone. It's normal pressure with failure of its relaxation. Here we can see another barium swallow with the same problem, which is achalasia. Here the esophagus is hugely dilated as well, smooth tapered lower end, parrot beak appearance, and healthy esophageal mucosa. Here we can see, on the other hand, mild dilated esophagus with shouldering and destruction of the lower of the mucosa at the lower end of or the lower third of the esophagus. So this is most probably cancer lower third esophagus, or like in a radiological term we can name it rat tail appearance. Here it's a malignant disease, so it's not, the esophagus is not hugely dilated. You can see here the effect of malignancy, which is shouldering and destruction of the esophageal mucosa all this way up to the stomach, and this is very characteristic for any tumor. Even in the colon we have shouldering, destruction of the mucosa. In the esophagus we have shouldering and destruction of the mucosa. So this is the fixed pattern of malignancy in all GIT. We have shouldering and destruction of the mucosa. So it's called red tail appearance. The question here can be, what are the common symptoms of esophageal cancer? What are the other investigations that are very important for this patient? So we don't forget to do endoscopy and biopsy for this patient. Here is another example of esophageal cancer, but here is in the middle third of the esophagus. So it's, so we can see here shouldering also and destruction of the esophageal mucosa. So it's and the red tail appearance of the cancer lower third esophagus with mild dilatation of the esophagus above. So it's very characteristic for cancer lower third esophagus. Here, this is another radiology of cancer esophagus. We can see here the shouldering and destruction of the mucosa, but here we can see an esophageal stent inside. This is a metallic esophageal stent that keeps the esophagus, is esophageal lumen patent. If the patient is unfit for surgery or has this advanced tumor, we can insert a metallic stent like this to maintain the lumen of the esophagus patent, and the patient can swallow easily without aspiration and without vomiting. Here, this is another problem of esophageal motility. Now we can see the esophagus has multiple areas of spasm and incoordination of its movement. It's an esophageal motility disorder as well, like achalasia, but achalasia affects only the lower end of the esophagus. This disorder called corkscrew esophagus, where there is spasm at different level of the esophageal wall along its whole length, and it's called corkscrew esophagus. It has the same symptoms like achalasia, like dysphagia. Now we move to now we will have this radiology, which is called Zinker diverticulum. This is an esophageal diverticulum which arises from the upper end of the esophagus, where this is the middle constrictor and inferior constrictor muscles of the pharynx, and this muscle, small muscle, is a circular muscle at the esophageal inlet. It's called cricopharyngeus muscle. This triangle is called triangle of dehiscence, and this is the weakest part in the esophageal muscle layer, and the esophageal diverticulum arises from this area. It's esophageal mucosa only, it's not covered by muscle, so it's a false diverticulum, it's not true diverticulum. True diverticulum is covered by all layers of the wall, like Meckel's diverticulum, for example, but this one is a false diverticulum because it's formed of mucosa only. Arise in this part, it become filled with esophageal content and fluid, so and then do compression effect from to the esophagus from outside, leading to dysphagia. So this patient usually suffer from dysphagia, and sometimes you can feel gurgling sensation at the neck of the patient. Also, when you do an X-ray for a barium swallow for this patient, you will find a diverticulum at the upper third of the esophagus, causing compression of the esophageal lumen with the air fluid level inside. This you will write the comment. Now we can see a barium swallow for a child. Usually, this X-ray is done if if the child in this age has a post-corrosive esophageal stricture. When a child swallow corrosive materials that lead to stricture of the esophagus at multiple level, so we do this kind of dye study to find areas of stricture in the esophagus and how we can treat them. So to write a comment for this patient, we write it's a barium swallow showing stricture in the middle third of the esophagus, and he's a child, so it's mostly post-corrosive esophageal stricture. Now we will move to another organ, which is the stomach. Now we will find the anatomical consideration in the stomach. The stomach is divided into the cardia, the fundus, the body of the stomach, and the pylorus. The pyloric area is divided into pyloric antrum, pyloric canal, and pyloric sphincter. This is the lesser curvature of the stomach, and this is the greater curvature of the stomach. We have three muscle layers, and this is the gastroesophageal junction, and this is the pyloric sphincter or pyloric valve. Now, this is the first study for the stomach. It's called barium meal. As you see here, the dye is filling the stomach. Here, mostly in erect position, so the dye is moving down to the lower part of the stomach, and here in Trendelenburg position with the head down, and the dye is filling the fundus of the stomach. As you see here, the stomach is hugely dilated. So, as we agreed before, huge dilatation of the organ is with a benign disease. It's not a malignant disease. So what can cause this huge dilatation of the stomach is duodenal obstruction or gastric outlet obstruction. So it's named gastric outlet obstruction, and usually it is due to cicatrized or chronic duodenal ulcer. It's a very, very common complication for and an important complication for a duodenal ulcer, which is fibrosis in the duodenal bulb with failure of the dye to pass through the duodenum into the small intestine with dilatation of the stomach. The patient suffer from, as well as history of duodenal ulcer, he suffer from repeated vomiting and abdominal discomfort. We can find in some x-rays that the stomach can reach down to the pelvis. This is another barium meal. with gastric outlet obstruction. You can find here these are the gastric rugae, and here you find the dye in the lower part of the stomach. This is very characteristic and it's named soap dish appearance. It's like a dish filled with soap. When the dye move from the esophagus down to the lower part of the hugely dilated stomach, the stomach you can see that is it's reached down to the pelvis, so it's called gastric outlet obstruction. No dye is bathing to the duodenum. Here you can see the duodenum empty with no dye inside. You can have some important question over this X-ray. What are the complications of the duodenal ulcer? How can you treat this patient? And for sure, you know that the ideal treatment for this patient is triangle vagotomy and gastrogenostomy as a drainage operation. Another barium meal with a hugely dilated stomach reaching down to, you can see here the iliac crest and here the femur and the hip joint. You can see the stomach is hugely dilated, reaching down to the pelvis with a soap dish appearance and failure of the dye to pass into the duodenum, which is called gastric outlet obstruction or cicatrized duodenal ulcer. Here the same, we can find a hugely dilated stomach due to cicatrized duodenal ulcer or gastric outlet obstruction. The same also here, no dye is passing from the stomach to the duodenum, usually dilated stomach reaching down to the pelvis. This is the iliac crest. You can see here down to the pelvis. This is not a filling defect. This is not a tumor. This is a peristaltic wave because it's not fixed in all the X-ray film. Here we can see it's a peristaltic wave, and here with contraction and here with relaxation. So the mucosa here is normal and it's not a malignancy problem. It's hugely dilated stomach, so we can exclude malignancy. Now we will move to, now also this is a hugely dilated stomach reaching down to the pelvis, and here this is the duodenum. As you can see here, after waiting about 1 or 2 hours, only thin rim of barium passed through the duodenum to fill here part of the duodenum, but it's hugely dilated stomach reaching down to the pelvis due to gastric outlet obstruction or cicatrized duodenal ulcer. Here we can find a hugely dilated stomach. Here we can find part of the stomach have filling defect like this. So it's mostly a malignant disease in the stomach affecting the body and the antrum of the stomach. The dye can pass to the duodenum and the small intestine, but with delayed passage. But here we can find the effect of gastric tumor. Now we can see another barium meal. Here is a part of the stomach with structure in the gastric antrum, which is mostly gastric body or antral tumor, leading to destruction of the mucosa, as you see here. So when I comment on this case, I can say that it's a barium meal showing mild dilatation of the stomach with filling defect or tumor effect affecting the body and the antrum of the stomach. You have to delineate the area affected. This is the fundus, this is the whole body of the stomach, is the antrum. You have to delineate the region of the stomach which is affected. Here, this is another barium meal showing structure in the area of the body or antrum of the stomach with passage of a thin rim of barium through it. So it's mostly cancer stomach. Here we can see that the structure is affecting the whole length of the stomach, which is called linitis plastica, which is diffuse infiltration of the gastric wall by malignant cells, and it has a bad prognosis. You can find here some questions that can be associated with this X-ray film. What are the clinical picture of this patient? Also, what are the other investigations that can be performed for this patient? And you have to mention endoscopy and biopsy as well. Also, what is the best treatment for this patient? For sure, if it's linitis plastica, it should be total gastrectomy. Now, this is another barium meal with a tumor here in the gastric antrum. As you see here, it's fixed area present in all films with narrowing of the lumen of the stomach and destruction and irregular mucosa. This is another X-ray with gastric antrum cancer. You can see here the destruction of the mucosa. Now we'll discuss some very important abdominal X-rays, which are usually emergency. Now we can see an X-ray anteroposterior view showing this X-ray is without dye. On the other hand, we can find barium and the gastrography dye, but this is a plain X-ray. It's without dye. You can see here air under diaphragm. So why we search for air under diaphragm usually on the right side of the patient, where this is a most common place to search for air under diaphragm is above the liver. Don't search here because here we have the gas bubble of the stomach. So it's important to find air under diaphragm in this part. This is another example for air under diaphragm. Now you can see the shadow of the liver and all this part is air. You can find here this is a rail tube inserted to do the decompression, and usually this is dilated intestinal loops. Usually mostly it's a jejunal loops, so it's air under diaphragm as well. Now we can see another type of X-ray which is also anteroposterior view, erect position, and you can see here multiple air fluid levels of intestinal obstruction. This is diagnostic for intestinal obstruction, but you should search for more than 3 air fluid levels. So this is 1, 2, 3, 4. We have one here, 5, 6, 7, 8. So it's a definite intestinal obstruction. You have also to search for concomitant air under the diaphragm, which is present in some patients with acute abdomen due to perforated DU with associated paralytic areas. But here we can see only the multiple air fluid levels. Here we can find this is an X-ray abdomen supine position. You can find here dilated colonic loops because there is colonic hostration in this area. In this X-ray, it's an X-ray supine position. You can find here dilated jejunal loops. It's an important question: how did you know that this is a jejunal loop? Through these lines. This is lines, mucosal lines reaching from one end to the other end of the bowel wall. It's called valvular convents or mucosal folds crossing from one side to another side, and it's characteristic for the jejunum. The colon is famous of colonic hostration. The jejunum is known by these lines, which are valvular convents or complete mucosal folds. The ileum appear like a structureless tube without these folds. Now we are moving to the radiology of the colon. Here, this is the rectum, sigmoid, descending colon, transverse colon, and ascending colon. This kind of radiology is called double contrast barium enema. Here first we start by injection of the barium inside, which is white in color. Then we inject air after the barium, so that the barium is adherent to the mucosal folds of the colon, and it gives a beautiful picture of the colon, and you can identify a small mucosal lesion of the colon. So this type of radiology is called double contrast barium enema. Here we can see up in the first two pictures, this is barium enema. You can see the castor through the inner canal, and with injection of barium you can see the rectum is white in color. After evacuation of the barium and the injection of air, you can see the thin rim of dye adherent to the mucosa, and you can see very clear the mucosal folds of the rectum and colon. So the upper part is the barium enema, the lower part of the picture is double contrast barium. Now we're going to describe this kind of X-ray, which is a barium enema, showing here in the part of the rectum there is shouldering and destruction of the mucosa, which is characteristic of apple core appearance of cancer rectum or cancer sigmoid colon. But how can we delineate the difference between the rectum and sigmoid colon in a radiology like this? There is a radiological line between the lumbar vertebrae and the sacral bone, which is a lumbosacral line. This line If the tumor is above this line, so it's a sigmoid tumor. If it's below this line, so it's a rectal tumor. If you can delineate, if you are not accurate, if it's a rectal or sigmoid tumor, you can see tumor in the rectosigmoid area. Also, we can see here multiple small globular outpouches in the transverse colon, and it's due to its characteristic colonic divertically here in the transverse colon. It can be described as small globular outpouches named colonic diverticuli. To write a good description about this barium enema, you have to say that this is a barium enema showing multiple filling defects appear here in the rectum and sigmoid colon. These filling defects are polyps. If the polyps are numerable and you can count them, so it's bilharzial polyps, like in this case, it's mostly bilharzial polyps. But if they are numerable and you can't count them, like hundreds of polyps, so it's mostly fab or familial adenosis polyps. So for description of this case, you have multiple filling defects. It's not globular outpouches like the vertical disease, it's a filling defect. The polyp is a filling defect, but the diverticular disease like a globular outpouches from the mucosa. Another example of barium enema with multiple filling defects in the rectum, sigmoid, and descending colon. This part is innumerable. You can count them. Mostly it's a fab or familial adenosis bulbosus coli, and usually it's a precancerous condition which should be treated by total proctocolectomy and ileoanal anastomosis. So you can have some questions. A very important question, which is what are the types of colonic polyps? What is the presentation of this patient? What's the ideal treatment for this patient? What should I do for the rest of his family? These are important questions that you should search for their answer. Another example for colonic polyps, you have to write a good comment about this. You can see here barium enema showing multiple filling defects affecting the rectum, sigmoid colon, and transverse colon, and it's mostly colonic polyps. They are numerable, they are multiple and innumerable, so it's mostly due to fab. Here, this is another type of barium enema. This is the rectum, sigmoid colon, descending, and transverse colon. And here you can see there is a rest of dye at the area of hepatic flexure or transverse colon with shouldering and destruction of the mucosa and failure of the dye to pass to the rest of the colon. So to write a good, so your diagnosis should be is obstructed cancer colon. The level of obstruction here in the transverse colon. And you can see here the shouldering and destruction of the appearance, destruction of the mucosa. And this is the apple core appearance, but half an apple, because the other half is obstructed and the dye can't pass through it. This is also barium enema, showing arrest of the dye in the transverse colon with shouldering and destruction of the mucosa and failure of the dye to pass to the ascending colon. It's an obstructed cancer colon. But we have to notice that the rest of the sigmoid colon and transverse colon have a strange pattern. This is loss of chronic hostration. This is not the normal hostration of the colon. So the cause of this loss of hostration is ulcerative colitis. It has this pattern of loss of chronic hostration, and it can lead to cancer colon. So it's cancer colon on top of ulcerative colitis, and this is very important because it will change your line of treatment. If you have only obstructive cancer colon, you can deal with the cancer and install obstruction. But if you have ulcerative colitis as a cause of the cancer colon, you have to resect all the colon, starting from the rectum up to the terminal ileum with ileoanal anastomosis. It's called total proctocolectomy with ileoanal anastomosis. This is also barium enema, strange pattern of colonic mucosa with the loss of its hostration. So it's characteristic of ulcerative colitis. You should know, you should have an answer for what is the presentation for this patient, what is the complication of ulcerative colitis, what is the lines of treatment of ulcerative colitis. These are also very, very important questions that can come with this X-ray film. Now we can see another barium enema with apple core appearance here in the transverse colon with shouldering and destruction of the. Now another X-ray film with barium enema and multiple filling defect in the rectum, mostly colonic polyps. Here another barium enema with loss of colonic castration due to ulcerative colitis is very characteristic. Another barium enema showing loss of colonic castration, and here arrest of the dye in at the splenic flexure with shouldering and destruction of the mucosa is characteristic for cancer colon or apple core appearance. Now we are going to discuss this type of X-ray. You can see here hugely dilated colon with two loops of colon with this is the mesentery in between, so it's called omega shaped colon, or three lines, one, two, three lines radiating down to the pelvis is called sigmoid volvulus, and it is one of the causes of intestinal obstruction. You can see here volvulus of the colon, and it's hugely distended, dilated with air and full of air, and we can say it's omega shaped colon or three lines radiating to the pelvis. This is the same problem. We have here the hugely dilated colon here, and this is a mesentery in between, but this is not a normal X-ray like the previous one. This is a barium enema. So you can see here barium enema, no shouldering or destruction of the mucosa, but we have a rest of the dye at the sigmoid colon, and it look like an S of spade, so it's called sigmoid barium enema, showing a rest of the dye at the start of the sigmoid colon, which is characteristic for sigmoid volvulus, and it's called S of spade, like the spade of the sigmoid volvulus. Thank you very much.